Welcome to pulmonary function testing. So this will be the first part of the presentation. I'll make a part two just so it's easier to sort of get and separate the concepts a little bit and give your brain a little bit of a break between some big concepts that we will be looking at here. And so the big thing we're looking at here is how the lungs are functioning. And we could always ask someone, how does your breathing feel? And we could always assess for dyspnea, and if the patient has one or two word dyspnea where they can only say 2 words before having to take another breath. We can look at those things, but it doesn't give us measurable data. And so when we're looking at something that's measurable, we can't just listen to the lung sounds and be like, yep, their lung sounds obstructive or their lung sounds restrictive. We can't really measure that. Those are all subjective parts of patient assessment. We need something objective. We need something that actually measures how bad the lung function is, and then based upon the lung function, we can look at the severity and determine the right course of medicines, therapies, so on and so forth. So you'll see this, it becomes very, very valuable, and you will do this in the hospital too. We do this in the bedside of patients in the hospital. We do it outpatient. We do it at health fairs, things like that, and we can look at it, and it gives us measurable data, quantifiable data, so that way we can actually look at the severity for that individual's lungs and then determine the best course of action. So lung function testing is becoming more and more prevalent, not only in the hospital for patients at the bedside, but even in some of the mechanical ventilators are starting to do some pulmonary function aspects, because we want to see how healthy or sick the patient's lungs are. So we're going to look at compliance, airway resistance. We're going to look at things like one of the ventilators does an FRC maneuver even. So when we're looking at this, this is not something that, hey, if you work critical care medicine, you'll never have to deal with this. This is something that's expanding and becoming more in use because it gives us that measurable data, and that will help us more effectively treat the patient. So here, we're going to talk mostly out of Egan's, chapter 19 here. And then I also put a link down there for the American Thoracic Society, and ATS is the organization. The American Thoracic Society is the organization that determines all the reliability results, all the pulmonary function test data, all that stuff. Those are the people that standardize pulmonary function testing. So it's not the American Association for Respiratory Care. It is the American Thoracic Society, and that's the website there for the Thoracic Society, and that's that link specific to the pulmonary function testing. So I recommend you check it out, but ATS is the governing body for pulmonary function testing. So let's get started. Gas exchange is the most important function of the lungs, and we talked about this in pulmonary A&P. When we're looking at someone's lungs, it's great if gas goes through their conducting airways, but we need that gas ultimately not just to go through the conducting areas, but also to get into the respiratory zone and provide that exchange of gas, right? So not only do we need it to get through the conducting airways, we needed to get to a point where we have that alveolar ventilation, right, where we exchange the gas between CO2 and oxygen into and out of the bloodstream. So gas exchange, I'll just put an E there, gas exchange is the most important function of the lungs, and this can actually help us see how much gas exchange is also occurring in the respiratory zone, right? We can actually see how effective the alveoli, or how healthy the alveolar capillary relationship is. So this is going to give us some valuable data. When we're looking at the ability of lungs to exchange gas, well, there's a lot of things that depend on the ability to exchange gas, and there's 4 primary functions. The diaphragm is going to be one of the big ones. The diaphragm and the thoracic muscles need to be strong. We need to have a good, strong diaphragm and thoracic muscles. So we need good diaphragm and thoracic muscle strength, right? So if the diaphragm and thoracic muscles are weak for some reason, we have a patient that's malnourished, or if we have a patient that is a neuromuscular condition going on, like Guillain-Barré or myasthenia gravis, that won't allow those muscles to contract very strongly at all, then we're going to have an inability to exchange gas efficiently, right? So we need a strong diaphragm and thoracic muscles, right? So diaphragm and thoracic muscle function is a big thing here. So I'll put the letter F for function. So diaphragm and thoracic muscle function needs to be appropriate. Most of the patients you'll see, and it's not every patient, but just most of the patients in usual that end up on mechanical ventilation tend to be on there because their diaphragm has fatigued. It's tired out. Their diaphragm and their thoracic muscles, their accessory muscles, have all fatigued. They've used them extensively to help breathe as much as they can while they have a pneumonia, let's say. So they've lost that skeletal muscle, because remember, these are both skeletal muscles, right? Diaphragm and your thoracic muscles. So your external intercostals, your sternocleidomastoids, all those things are skeletal muscles. So they can fatigue. And so we need those muscles to function appropriately in order to have the patient exchange gas effectively. Well, let's say someone is given a dose of paralytic. So we give someone a dose of succinylcholine or Pavulon or something like that. It's going to be a paralytic. Well, what happens to the muscle function of the lungs, the diaphragm and the thoracic muscles? Well, they're going to be paralyzed as well. So those muscles won't function, and therefore that patient is not going to exchange gas very well. So you can see it's important that the diaphragm and the thoracic muscles have good, strong function. And this is also where nutrition comes into play with some of our patients on mechanical ventilation. If they don't have the proper nutrition, the proper calories, the right type of substrates that are going into their body, then they're not going to have a good muscle recovery from what their muscles were doing, and then they're not going to be able to be strong enough. Their muscles, their diaphragm and their accessory muscles are not going to be strong enough to help them ventilate if we take them off the ventilator. So this is a very key part that people tend to overlook, especially when we're looking at critical care medicine. So we need good, strong diaphragm and thoracic muscles. In pulmonary function testing, guess what? It will give us information about how these muscles are functioning. The second point down there, patent airways for unobstructive gas flow to the respiratory zone. So I'll put the letter P for patent or open. Right, you could put open airways for unobstructed gas flow. We want to see how open that lumen is. Remember when we were talking about Posey's law and we had a big lumen and a tiny lumen, right? And we can get a lot more gas to flow through that big lumen a lot easier and faster than we can through this small lumen. And so this pulmonary function testing, we can see how open or how big the radius is of the airways by looking at the gas flow, right? The faster the flow, the more open the airways. So open airways equals a really fast flow rate, right? Small airways equal a really small flow rate. So I can actually see by measurable data how open or closed the airways are, right? And when the airways get small like this over here, when they get small over here, that's when we start to see, we call it an obstructed gas flow, right? Because there's something that's blocking the ability for gas to flow through there. It's like a kink in a hose. It's obstructing the ability for water to flow through that hose, right? So when we do the pulmonary function test, one of the big things we'll look at is the patient's flow rate, right? The faster the flow rate, the more open the airways are, the bigger the radius. The slower the flow rate or the lower the number, the smaller the airways are. So someone that has asthma where their airways become very, very, very small, their flow rates are going to be very, very low because they have a smaller lumen, right? They have a smaller radius. someone that responds well to their bronchodilators after we give them the bronchodilators, and they go from a small lumen to a big lumen over here, then their flow rates will go up, and that number, that numerical value, will also go up. They'll have a faster flow rate. Right, so we can look at the patency of the airways for unobstructed gas flow to the respiratory zone. So the smaller the number, the less gas is actually going to and from the respiratory zone. That's pretty bad, right? That means that their ability to exchange CO2 and O2 is going to be very difficult, and it will tire out the diaphragm and thoracic muscles ultimately. The third point here is the cardiovascular performance, and I'll just write CV here. The cardiovascular performance to circulate the blood through the lungs. Why is this a big deal? Because if there's no blood being pumped through the lungs, then we're going to have a big issue of getting the lungs to function normally. Remember, where does the respiratory zone get its nutrition, get its healthy blood flow nutrition from? Well, that tissue of the respiratory zone gets its nutrition from the alveolar capillary membrane. It gets it from that relationship. It steals it from the alveolar capillary membrane. And if our right side of our heart is not functioning well, or if our left side of the heart is not functioning well, we're going to have an issue with blood flow circulating through the lungs. People with left-sided heart failure, which is congestive heart failure, their blood will back up into their lungs, and it causes what's called cardiogenic pulmonary edema. The cardiogenic means, hey, the reason for the pulmonary edema is the heart. So cardiogenic, like Genesis, the heart generated the pulmonary edema. And you're going to see that will build up pretty much what's called pulmonary edema. So there's blood flow that backs up in the lungs because that left ventricle isn't squeezing anything out. So blood will back up, and it will go across the AC membrane into the respiratory zone and start filling it with this frothy secretions in there. So that's that cardiogenic pulmonary edema. So that's going to obviously decrease your lung function because you have a bunch of fluid in there. It's going to dilute surfactant, right? It'll dilute surfactant, and even with your J responses, J receptors and all that thing, you can have bronchospasm, so this patient can go into wheezing, as well as a restrictive effect because their lungs can't expand because now you're diluting surfactant and you're putting a bunch of fluid in that area. So that's going to increase surface tension. So now you're going to have a restrictive and an obstructive situation going on because this patient's heart is failing. So this is something big to pay attention to when we see a patient with left-sided heart failure or congestive heart failure come into the emergency room. They might be wheezing and working hard to breathe. Well, their cardiovascular performance is very low, and it's causing this whole issue over here where blood is backing up into their lungs, right? They're filling up with that fluid, and so yes, they're going to be in a bronchospasm. Yes, they're going to have a bunch of fluid, so they're going to be breathing fast and hard, and they're going to have a hard time getting oxygen into their bloodstream. Believe it or not, the pulmonary function test can actually look at both how bad they're wheezing, or their restrictive effect, as well as their obstructive effect, right? So this can actually give us quantifiable data. Now, are we going to do it on a patient that can't breathe, that's on a lot of oxygen? No, but when we're looking at this, we can do this outpatient. If we have someone that has steady congestive heart failure, right? It's under control. They're coming into the pulmonary function lab. We can actually look at the compliance and resistance of the lungs and look at how and quantify how much it's affecting the lungs. It's pretty interesting. And then finally, the last point on here is diffusion of gas through the AC membrane. So just like the alveolar capillary membrane, right? So the diffusion through the AC membrane, we can actually measure this with what's called the DLCO. And we talked about this before in pulmonary A&P, go figure, right? So we can give the patient a small percentage of carbon monoxide. Like I said, small percentage. You get more carbon monoxide at the bus stop, right? So very, very small percentage of carbon monoxide. And we have them breathe it in, hold their breath for about 10 seconds or so, and then exhale. And we're going to measure how much carbon monoxide we gave them, which is a known value, and then how much carbon monoxide they exhaled. If they exhaled almost everything that we gave them to begin with, that means hardly anything got diffused into the bloodstream. And you know carbon monoxide loves hemoglobin, right? And so when that happens, we know that there's something wrong with their diffusion through the AC membrane. So there's something causing an inability to cross the AC membrane, like pulmonary fibrosis, or scar tissue developing, a restrictive effect, destroyed lung tissue. There's a bunch of things that could be causing that diffusion defect. So it gives us a valuable insight, but not only that, it can help us quantify how bad that diffusion is. Instead of just saying their diffusion's bad, we can actually see numerically how severe it is. Right, and even patients that undergo chemotherapy, chemotherapy and radiation therapy can cause inflammation of the AC membrane, which means their DLCOs will be decreased. They're going to have a harder time getting things across into their capillaries because they're increasing the thickness of the alveoli. So we'll actually we'll do these tests on these patients that are undergoing these procedures, and the doctor will then interpret that and titrate the level of chemotherapy or the strength of the chemotherapy the patient's getting because of how it's affecting their lungs. Because obviously you don't want to destroy their lung tissue at the same time. You kind of need your lungs to survive as well, right? So there's 4 things that give the ability to exchange gas. And we're going to look at all these things. So PFTs will give information about all of these things. So pulmonary function testing is very, very helpful diagnostically, as well as helpful therapeutically, as well as we know how aggressive to treat this patient and with what things based upon their severity. And we also know where they're at in their disease process. And it can even actually help us determine what type of disease process the patient has in the first place. Do they have something like asthma where their flow rates get really, really low? Or do they have something like pulmonary fibrosis where their lung volumes and capacities are very, very low? So PFTs can also help us zero in on what type of pulmonary disease or condition the patient's going through. And there's even some conditions that have both going on at the same time. Like we talked about with pulmonary edema, it's both a restrictive and, if it causes bronchospasm, an obstructive disease process as well. Isn't that crazy? So we can even see combined restrictive and obstructive with a pulmonary function test. So you can see the value of this process becomes very, very key in how we treat these patients and how aggressively we treat them or how minimally we treat them, as well as it can make decisions about their prognosis ultimately. So this will help aid in diagnosing patient, like we talked about before, restrictive disease like pulmonary fibrosis, obstructive disease like asthma, or even both, right? We can also see how severe the disease is, right? We can determine the severity based upon how fast their flow rates are, how low their flow rates are. Or we can look at how severe they are based upon how small their lung volumes are. Or in a case of someone that retains a lot of gas, like emphysema, where they have a lot of gas left over. Remember when we talked about auto-PEEP? If they have a lot of gas left over, if their FRCs are really, really big, their functional residual capacity, hopefully you remember that, then we know that is a sign of the severity of their air trapping, right? We can also determine the need for different types of therapy. How much medicine do we give them? With asthma, we can see how much bronchodilator they might need, or if they also need to be on a controller medicine like an inhaled corticosteroid, right, like a Qvar or Flovent, right? So we could also see what types of therapeutic interventions as well, as far as like machines. If they have a lot of secretions in their lungs causing an obstructive effect, then we can use things that help shake up the lungs and get that mucus out. And there's a lot of different options for us if we know how severe it is. And so this can help us determine the need for different types of lung therapy that we will be administering. That ultimately too, here's one of the really cool parts about this is we can actually show numerically, right, with measurable results, how much the patient responded to what we did. So let's say I have someone with asthma and their airways are really, really small, right? Bronchospasm caused their airways to be really, really small and constricted in. And then I gave them a bronchodilator. And so now they transition from there over here to where now their lumen's much bigger. Well, if I did a flow rate, if I checked a peak flow rate over here and it was very low, and then I checked a peak flow rate 15 minutes after I administered, 10-15 minutes after I administered an albuterol or a bronchodilator, and I see the flow rate has actually increased, then I've actually seen how effective that therapy is, right? We can actually see the change and measure it and say, hey, that change is greater than 12%. That patient responded really well to that therapy, right? So that's one of the things. And then we could also see if that patient didn't respond at all. Let's say we gave that bronchodilator and their flow rate didn't change after we gave it, then we know that wasn't an effective therapy, and we need to look for other complementary therapies that will work for that patient. So it was very, very helpful. All right, so what are our expectations for respiratory therapy, right? So we need to be able to know how to perform these tests, and hopefully in the lab we'll at least simulate these if we cannot do them. And then you will be doing these in the hospital as well, as is my hope, right? So I want you to be able to know how to perform these tests. Even if you plan on not working in a pulmonary diagnostics lab, it's still important you know how to perform these tests. Because like I said earlier, these aspects of pulmonary diagnostics are actually creeping into critical care medicine, and this is a good thing. This is a good thing for you, as a good thing for the care of our patients altogether, because then we have a lot more measurable, quantifiable data, and that actually tells us, are we doing the right thing? Are we getting enough response? Should we do more? Should we do less, right? This is what we're looking at here. So you should know how to perform the test, and these are even asked of you when you take your board exams for respiratory therapy. They ask you which of the following is the correct way to perform a certain pulmonary function test. So it behooves you to actually be able to do this, understand it, even if you don't plan on working in a diagnostic setting. Right? This is great. I want you to be able to obtain accurate information and know what accuracy is when it comes to it, and we'll talk about that as well. Be able to troubleshoot, calibrate, and disinfect equipment is a big thing. And when we talk about disinfecting the equipment, especially nowadays with all the different types of respiratory things going on, it's very important that we take a big role in preventing the spread of anything respiratory, right? So troubleshooting the machine, calibrating the machine, these are all things that you might have to do, especially if you work in a diagnostic setting, or if you work in a setting that uses a lot of these machines daily. You're going to have to be able to troubleshoot and calibrate these. And every day that I used to do 1 day a week in our PFT lab, I would have to calibrate. Every day that we use that machine on a patient, you have to have it calibrated before you use that machine for that day, because that shows that that data is accurate that we're collecting from that patient. So it's just like tearing a scale, right? When you put if you've ever done chemistry and you had to tear a scale, or science and you had to tear a scale, make sure the equipment is calibrated and zeroed out before you start measuring things. And that's exactly what you're doing here. You're just making sure the machine's measuring the flow rates well, it's measuring the volumes well. I want you to be able to have basic interpretation of the measurements. This doesn't mean you're going to be doing the diagnosing of this patient, right? A patient comes in and you see their flow rates are very, very low, right? The patient can hardly get any gas out. Then you're like, oh, you have asthma. No, that's not for you to do. That's for the pulmonologist to do. It's your job to get the best test possible, right? But they're the physician, they're the diagnoser, right? You're not the diagnoser. But I want you to be able to interpret the measurements. I want you to understand what a restrictive looks like. I want you to understand what an obstructive pulmonary function test looks like. I want you to understand what a combined restrictive and obstructive pulmonary function test look like. And we will practice those in part 2. And I want to make sure that you are able to interpret those so that way you understand the data as well. I want you to see what it means if a DLCO is low or if a DLCO is high. I want you to be able to look at those things and have that good understanding of what we're looking at. So if someone hands you a pulmonary function test, even though you're not allowed to diagnose the patient, I want you to be able to understand what type of process is going on. And this is something that is asked of you. Hey, what are your thoughts on this? All right. And then even in the board exams, they'll ask you interpret this pulmonary function data, and they want you to see if it's restrictive, obstructive, both, what type of disease they probably have, so on and so forth. Even though you're not the diagnoser, they want to make sure that you understand these key components of diagnostics. All right, so what we need to do, right, is you need to be able to identify the pulmonary impairment. So that's where we're looking at restrictive versus obstructive flow rates, right? Restrictive or obstructive disease process. So we're going to be looking at volumes or capacities, and then we're going to be looking at how fast they blow out, which would be flow rates. We need to see how severe the impairment is. So this is where, you know how we talked about hypoxemia and how 80 to 100 PaO2 was normal, and then we had mild severity of hypoxemia if it was 50 to 79, right? So on and so forth. So when we're looking at this, we need to be able to determine the severity based upon the numbers, and we'll go over the different levels of impairment, right? And this is going to be a big key, and then understanding the diagnostic and therapeutic roles that this plays. So this can help you be a valuable member of the team and not just be someone that does the procedure and walks away. I want you to have that deeper understanding so you can have recommendations and or input for the care of that patient. So diagnostic and therapeutic. When we're looking at this testing, diagnostic indications. Diagnostic means we're trying to figure out what's the cause, what's wrong with it, right? Hence the picture there. Is there a lung disease? Do they have perfectly functioning lungs? If they have normal volumes and capacities as well as normal flow rates, there would be no diagnostic reason to see that there was currently lung disease going on. And so you would in fact rule out a lung disease. And we've done this before, right? I've had patients that came into the pulmonary function lab and they had a normal pulmonary function test. However, when they go into it, it ruled out pulmonary function problem, and then now they're going to look at a cardiovascular problem, right? They can look at other causes for that issue, right? What type of impairment is present? Is it an obstructive disease? Is it a restrictive disease? Is it both? Right? How bad is it, right? What severity? Is it mild, moderate, severe obstruction, right? That's going to determine how we take care of that patient. So how bad is that impairment and how are they trending? Is there more than one type of impairment? In other words, do they have a combined condition like an obstructive and restrictive process? So an example of this would be someone that has COPD or emphysema, right? Imagine a patient that has emphysema coming in and then they're developing a pneumonia at the same time. So then they're going to have both an obstructive and a restrictive process, because pneumonia inflames the AC membrane, and we talked about this in pulmonary A&P. Pneumonia inflames the AC membrane in that loose space. Remember all that lymph tissue? It inflames that AC membrane, and it impedes the ability for the lungs to expand. It actually makes the lungs collapse a little. That's why we'll see things like atelectasis on their x-ray. So their volumes will be decreased, and their flow rates, because they're emphysematic. Remember the old, this is your normal conducting zone, and then this is the structure of your conducting zone. With emphysema, it gets destroyed, it loses its structure, so this area sort of collapses, so it becomes obstructive, right? It becomes narrow, especially when they exhale. So now they have a combined condition where their pneumonia is causing restriction, and their emphysema, which is all the time on them, is being obstructive. So now they have both of them present. Isn't that crazy? Can there be multiple lung diseases? Can multiple lung diseases be separated, right? Can we look at how bad they are? Can we separate them? Therapeutically over there, is the therapy we're doing indicated? Like we talked about before, if I give someone a bronchodilator and their flow rates don't change at all, less than 12%, then that may not be the right therapy for that patient. We might have to look at something else, right? So it can help us determine the right therapy ultimately that's effective for that patient. What treatment is the most effective? That's exactly what we're going to look at. How reversible is the process? How much effort or how much therapy or what dose of medication does it take to help get them back to their baseline status? So let me talk about this a little bit here. When we're looking at someone that has asthma, right? And so I'm just going to pick on asthma for a second here. They're at baseline, it might be fully reversed, but over time their airways can be remodeled. In other words, the lumen of their airway or the radius of their airway can become smaller over time, because that musculature, that smooth muscle that lines the inside of your lungs, right, can actually become built up, similar to a bodybuilder, right? So the more severe, the more remodeling that can happen. And what happens there is at baseline, even though they're reversed, their radius is still smaller because of the thickness of that smooth muscle that's in their lungs, that muscle that surrounds the inside of their conducting and respiratory zone. So when we're looking at this, we have to look at bringing a patient back up to what their baseline flow rate is. I'm not going to look at what's predicted for them, right? I'm not going to look at what's predicted for someone, their height, gender, and age. I'm going to look at something that's predicted for them at their baseline. Because if I try to compare them to a healthy person, they'll never attain that healthy number. I need to compare it to their baseline values, and that's why it's important for people that have things like asthma and emphysema to have pulmonary function tests regularly, so they know their baseline, so we know where they're at in their disease process. Okay, I'll get off that little high horse there. So therefore, we can look at if treatments can be evaluated for their effectiveness, right? If we know that a bronchodilator is not working to change their obstruction, then we know we need to start looking at other different types of interventions or therapies we can do for those patients, right? Do we need to give them positive airway pressure and stent open those floppy airways to allow for better breathing in and out, right? Things like that. And then when we're looking at down here, is rehabilitation feasible, right? Are we able to get this patient to qualify for something like pulmonary rehab, which is just an amazing, amazing program if people can qualify for it. Multiple therapies are involved in pulmonary rehab. We have the registered dietitians, we have physical therapy, we have occupational therapy, we have respiratory therapy. All of us are working together as a team to help rehab this patient and educate them and get them to the most functional they can possibly be, where their activities of daily living aren't impacted as greatly by their COPD, by their pulmonary function, right? And we're there to ultimately help them live a better life by having them do the right nutrition regimen, the right therapy or the intervention, how to live and function with an oxygen tank, and that they're not just tied into their lazy boy watching their television all day, right? There's more to it. And so I love pulmonary rehab, and this can actually help us see if someone's qualified for a therapeutic intervention like pulmonary rehab, right? It's not cheap for pulmonary rehab, but it is very, very beneficial and is shown to help these patients' quality of life. All right, so what are some indications for pulmonary function testing? So when we're looking at indications, we need to quantify, right? Get a numerical measurable value. That's what we're talking about. Quantify means we get a number and a measurable value, right? It's not a subjective, it's objective. So we need to quantify changes in their lung function, right? So what would be an example of this? So if we have a patient, and I love trying to do examples for you guys, if we have a patient that has has dyspnea when they're walking around, so it's called DOE, dyspnea upon exertion, or DOE. Right, I need to find what's causing it. So I need to quantify their changes in lung function. So one of the tests that we'll do is we'll do a forced vital capacity. And I want to see how fast they can breathe. So I want to look at their flow rates. And then I want to see how deep they can breathe. So I'm going to look at their volumes and capacities. Supposed to see capacities. All right. Capacities. All right. So I'm going to look at their flow rates and their volumes and capacities. So the flow rates tells me things like an obstruction, like they have bronchospasm going on, or they have an emphysema going on, something's obstructing their airways. And then I can look at the volumes and capacities and see, why are they dyspnea? Is it there's something that's obstructing their airways, or is it something that's restricting their airways, that's squeezing in, like a pleural effusion that's developing, that's pushing the lungs in? Or is it pulmonary fibrosis developing, like an interstitial lung disease that's causing scar tissue to develop? Right? So I can look at this and I can quantify changes in lung function. So I can sort of see how bad it is and what the reason why they could be developing that dyspnea on exertion. I can look at the need to quantify, once again, we're getting measurable data here, the therapeutic effect. So if I have someone that has asthma and they have a very small radius, and I want to see how effective it is at opening up their lung tissue to a bigger radius, right? Because it's a bronchodilator. Then I'm going to give them a bronchodilator. I'm going to do a pulmonary function test without the bronchodilator, and I'm going to see how low their flow rates are, right? So over here would be a low flow rate. Low flow rate. And then over here, hopefully I want to see how big of the flow rate change, because remember, if we go from a small radius to a large radius, we should be able to get more gas flowing through that bigger hose, through that bigger radius, right? So I'm going to look at that flow rate change, right? How therapeutic was that bronchodilator? And hopefully it's at least 12% change from before, right? So we're going to measure it before we give them the bronchodilator, and then we're going to give them the bronchodilator, wait 10-15 minutes, and then measure the test again and see if their flow rate did improve and how much it did improve. Pulmonary diseases, especially if someone has like pulmonary fibrosis or COPD or asthma or chronic bronchitis or bronchiectasis or cystic fibrosis. I don't know if I already said that one. If anybody has any of these chronic pulmonary diseases, whether restrictive or obstructive, we can keep tabs. In other words, we can trend how their pulmonary function is doing. If we see that their pulmonary function, their flow rates keep decreasing faster than what they should for their age, then we might be able to step in and add something like an inhaled corticosteroid, and we can add different types of therapy, a blocker, things like that, that can help reduce the digression that they're doing if they're digressing too fast, right? So we can actually keep tabs and trend it and know when we're going to go into different categories of therapies. We can use them to evaluate the risk for people that are undergoing surgery. So we're looking for post-operative pulmonary complications. One of the biggest issues out there, especially for patients that are undergoing surgery like gastric bypass surgery, is the possibility for their lung function to decrease severely after the surgery. A lot of those surgeries require general anesthesia, and as we know from pulmonary MP, that general anesthesia, that nitrous oxide, not nitric, but nitrous, NOS. The nitrous oxide, that laughing gas, makes it harder for people to breathe because it's a lighter gas and it is less distension on the pulmonary surface, so we have a lot more atelectasis. So that patient's more prone to lung collapse, on top of having a significant body habitus that's pushing their chest wall in, right from their abdomen and from the anterior part of their chest. It's pushing their chest wall in. So they already have something that's pushing their lungs closed, and now we're giving them a gas that can also push their lungs closed. And this can also be setting up to cause a post-operative pulmonary infection like a pneumonia, right? Because if you have a bacteria in there, and especially if you're paralyzed for surgery, which most people are, for general anesthesia, if they're paralyzed, their mucociliary transport is not working. So they're not getting rid of bacteria and stuff that normally they would have cleared. So they're at high risk for postoperative pulmonary complication or a pneumonia. So when we do the pulmonary function test, we can see how healthy they are. If they have really good flow rates and good volumes and capacities, they're at a lower risk for postoperative pulmonary complications compared to someone that comes in for pulmonary function test and they have very low volumes and capacities, they have very low flow rates, then that could be a bad sign that they may have a higher risk of a postoperative pulmonary complications and they may have to hold off on surgery. Isn't that crazy? And then finally down here, determine the disability of the lungs. I think it was California, if your FEV1, which is one of the tests that we'll talk about, the FEV1, if it's less than a liter, the flow rate, a liter per minute, it's going to be a sign that they are actually qualify for disability. And so it can ultimately come to funding, going on a government assistance, things like that. So you'll see that as well. So you're looking for their level, and then it might actually look at things like their level of disability as well. All right, so what are some contraindications for pulmonary function testing? Well, the first one's going to be hemoptysis. And if you don't remember, hemoptysis is coughing up blood, right? That's that blood that you cough up. If someone's actively coughing up blood, that's not a good sign. It could be a couple of different disease conditions out there. We'll talk about that in disease class. But if someone's coughing up blood, they're not healthy enough to be doing a pulmonary function test. That's a patient that we're going to look at their lung function in other ways, like an x-ray, right? Still subjective, or a CT scan of their chest, right? Other ways we're going to look at their lung function, but we're not going to have them do, hey, breathe deep into this device if they're coughing up blood. That's not a good sign. Pneumothorax, if they have a hole in their lungs, that's not good. And doing a PFT where you actually have a patient breathe really deep and blow out really hard and fast, it can actually tear more at that hole in their lungs and make it worse. So if a patient has an active, untreated pneumothorax, it is a contraindication for testing. If the patient has a myocardial infarction or a heart attack, that's a sign you don't want to do it, right? A recent MI is what it should say, a recent or current MI. If a patient's having a current heart attack, you shouldn't be putting them under that stress, because you're also putting the heart on a little bit of stress doing this procedure as well. Just a little bit. The lungs that's mostly go through the stress on this situation. So if the patient's had a recent MI, you probably should hold off until the physician approves that. that. Now, if a physician approves it, then you should be good to go. But if they had an MI within the past week and a physician hasn't approved the test, we probably should get an approval before moving on with that test. If someone has a pulmonary emboli, an untreated, active pulmonary emboli where they had that blood clot that's just stuck in their pulmonary trunk or somewhere in their lungs, or multiple pulmonary emboli, that is a contraindication because we are putting stress on the lungs and the heart. That can exacerbate or even move that clot or bone fragment or adipose tissue or amniotic fluid. It could actually move it and have it continue on. If a patient's experiencing acute chest pain, you don't want them to continue on with the test. The chest pain or angina is not acceptable. So if they have that unstable angina or chest pain, they need to get that taken care of. And that's not something that we're going to do. This test is not an emergency test. It's usually a diagnostic test when we do it. And so if the patient is unstable, especially if they're experiencing acute chest pain, a PE, an MI, a pneumothorax, or coughing up blood, those are all signs that there's more serious problems going on that we need to fix before we can get accurate data with a pulmonary function test. Dementia or confusion. When we're looking at that, especially doing a pulmonary function test, it's going to require us to give a lot of directions to the patient. And so I'm going to tell you to breathe deep and then breathe out slow, but all the way. Then I'm going to tell you to pant. Then I'm going to tell you to do all these different types of breathing. And it's going to be very hard for some of these patients to follow those directions to get that lung test done. Now, there are different lung tests out there. There's a test called forced oscillation, and some of you may have heard of it before. If not, please look it up. Forced oscillation, the patient just breathes naturally on a mouthpiece, and they don't have to do any weird types of deep breathing or anything, and it can actually help tell us about their lung function as well. So there are other options out there, but dementia or confusion, the patient may not be able to give us the appropriate breathing techniques in order for us to get the right numbers. Then finally, if they've had a recent cataract removal, that's also a contraindication. We're having them take a deep breath. And have you guys ever had to your ears pop going up and down altitude or in an airplane? Right? It's that ocular pressure can be part of it. And so with the deep breathing and everything, it can actually put ocular pressure on the patient with thoracic pressure changes, because we're breathing deep, we're holding our breath, we're blowing out, right? We're changing thoracic pressures, and changing thoracic pressures can change intracranial pressures and therefore also change intraocular pressures. So that can put actually stress there as well. Pretty cool cat though. So restrictive, obstructive, or both. So remember, these diseases can happen together, or these conditions can happen together or separately. I can have someone that just has emphysema that's going to have an obstructive disorder. I can also have someone that just has pneumonia and they'll be having a restrictive disorder, right? Because of the swelling of the respiratory zone. Or I can have someone that has emphysema, which has an obstructive disorder, and they develop a pneumonia. Well, now they have both, right? So they can happen together or separately. And so that's what we're going to look at with the pulmonary function test. Are they happening together? What type is it in the first place? And do we have both going on, right? Or is it a separate thing? So let's look at the obstructive part here. If there's a block in the gas from flowing through the tube, right? So that's where we look at asthma, right? And we see that they have a normal large lumen, but now it goes to a very small lumen, right? Very small lumen, because all this bronchospasm that's going on around it. And then their lungs are also filling with secretions. We'll talk about that when we get there as well. And so something's blocking gas from flowing. So it's like you going outside with your garden hose and you have the hose nice and open, but then you start to kink it off. is water going to flow through that hose very well when you kink off the hose? No, it's going to diminish, right? And so that's exactly what's happening here. There's something blocking the flow of gas, and usually it's the lumen of the airway that decreased. Well, what's going to happen? Well, this is going to make it harder to breathe. It'll increase your airway resistance. So remember, the calculation for airway resistance is pressure over flow in liters per second. So when we're looking at this, their airway resistance would increase. Normal is 0.5 to 1.5 centimeters of water per liter per second. So when we're looking at this, when we do a pulmonary function on this patient, and let's say we have it at 4 centimeters of water per liter per second, right? Then that would be an increased raw, and that could be a sign that this is exactly what's going on. So remember, this increases your transairway pressure. Remember from chapter 2 in your pulmonary MP book, transairway pressure is the pressure gradient from the pressure at the mouth to the alveoli. Well, why did I put this in there? Well, let's say you have this asthmatic patient up here, right? That's on a ventilator. That means it's going to take a lot of pressure to get from the mouth to the alveoli. But once we get to the alveoli, a lot of that pressure will be lost, right? Because it's going to take a lot to get there, but not a lot's going to transfer there because a lot of it will be lost in translation. So we could use something like 50 centimeters of water pressure. And I'm not exaggerating on that. That's a high pressure, but by the time we get to the alveoli, because there's so much that gets lost because of the radius of the lumen being small, we might only have 20 centimeters of water pressure that actually gets exerted on the respiratory zone, on the alveoli itself. So even though the pressure it took to deliver that breath was super high, the pressure on the actual respiratory zone itself is so low. This is trans airway pressure. And that's increased because there's a high airway resistance, because there's something blocking gas from flowing all the way down there, right? So the bigger the transairway pressure, the bigger the gradient between these two, mouth and alveoli, the higher the raw, the bigger the blockage there is in their transfer down there, right? The worse their asthma is. So you'll actually see this in mechanical ventilation. I wish we were in the lab right now. I would show you this. But you could see that if someone has severe bronchospasm, it's going to take a lot of pressure, but hardly anything is going to make it to the alveoli, right? We're going to have poor alveolar exchange. Let's look at restrictive over here. Let's draw a separation line. Restrictive disorders, something's blocking the lung from expanding. Whether it's something externally or something with the tissue itself. So when we're looking at this, it could be something like a kyphoscoliosis or a pleural fusion that's squishing the lung tissue from the outside, right? Could be, like I said, a thoracic cage issue, like a pectus excavatum, where there's that dent in on the chest wall. There's something that's restricting the movement of the lungs. So that could be a pneumothorax, would be a restrictive, right? Because it's pushing in on the lung tissue. So it's whatever it is, it's causing the lung not to expand. So it could be something externally, or it could be the tissue, right? And so when we're looking at this, something's causing the less tissue expansion, and ultimately the compliance of the lung is going to be decreased, right? We're going to have a low lung compliance. Do you remember the calculation for that again? I hope you do. Remember? Hopefully you do. Volume over pressure, right? How much pressure, how much volume do we get for the amount of pressure? So it's their tidal volume over the pressure change. So the change in volume over the change in pressure. Remember, I had you guys calculate it. So the lower the compliance, the more restricted their disease is. So if someone has a severe pneumonia, their compliance is going to be really, really low. on the ventilator. If someone has high compliance, a super high compliance, like let's say with late stage emphysema, their compliance will actually be very high because they lost their elasticity. They can move a lot there. So with restrictive disorders, the lung compliance is super low, like with pneumonia. Like we see with viral pneumonias out there, right? Especially the more recent ones, the swine flu, the COVID-19, all those viral pneumonias cause very low lung compliance, right? And so this is something you will calculate. You'll calculate raw and you'll calculate lung compliance every time you go in to see a mechanical ventilated patient. So don't forget those equations. Those are things that you'll be using. So remember, restrictive disorders can be from the lung tissue resisting expansion, like we see with pneumonia, or pulmonary fibrosis, where there's scar tissue, or with pneumonia, where there's that loose tissue there's that lymphatic in the loose space that's pushing away from the AC membrane. Or it can be something extrathoracic, right? So if we have the thoracic cage and we have the lungs, and then we have a massive pleural effusion building up in the left side, it's going to start causing collapse of that left side of the lung because we have more pressure being exerted on the lung tissue. And so that's going to be restricting the volume of the lung overall. So it can be extrathoracic, right? It can be outside the lung tissue, or it could be something wrong with the lung tissue altogether. So outside the lung or lung tissue, either way, something's causing a decreased expansion. This is a picture directly from your book, and this is looking at normal versus abnormal on obstructive on the top left here. Something's obstructing the airway. So if I had a giant tumor growing in the airway over here, all right, let's just say this is a vascular lung tumor, it's in my conducting airways, right? Or it's in my transitional airways. It's something that's causing a narrowing or a smaller lumen. I have a good lumen, and then when this happens, I have a smaller lumen, right? So I have a smaller lumen, so something's going to obstruct that nice, good laminar flow from getting through there. So it's going to increase my turbulence. So I'm going to have turbulent gas flow. It's going to be more raw. My transairway pressure is going to be increased, right? So I will have a lower ability to get gas all the way down and inside here. Normally, if I had a nice and open situation, I'd have a good open alveoli, but in this situation, something's blocking gas from flowing in, and also it blocks gas from flowing out too, because once it's in here, it's got to come back out, right? That CO2 and all that bad gas has to go back up and out, right? There's no third option. It's either in or out. And so when it tries to come back out, there's gas that's being obstructed from flowing out as well, out of their lungs. And so this is where we see gas gets trapped and their alveoli becomes bigger, right? And then the alveoli gets bigger the next couple of breaths. This is where we get that hyperexpansion or that increased FRC ultimately, where we see that with people with severe emphysema, they get stretched out and it pulls away and destroys some of the capillaries because it gets stretched out, and it pulls away the elasticity, so that way they don't have near as much, they have good compliance, but they have low elastance, therefore their ability to recoil and collapse is decreased overall. Over here, so that's obstructive. Over here is restrictive, and over restrictive says, okay, over here on the left, this would be a normal open airway, normal size alveoli, then we get back out. Over here we have an issue where the alveoli is much smaller, right? Or the respiratory zone is being impeded on. So the alveoli or the respiratory zone is the inability to stretch. Remember, it could either be from external, where it could be like a massive pleural effusion or a pneumothorax building up and pushing it in, or it could be the tissue itself is developing scar tissue, or let's say that we had that cardiogenic pulmonary edema where it was causing decreased surfactant or surfactant dilution and causing the surface tension to increase, and therefore it's collapsing it. Right, either way, there's a restrictive process going on. So when we're looking at pulmonary function test, we're looking at their flow rate for an obstructive disorder, and then we're looking at their capacities and volumes for restrictive disorder. So if they have low capacities and volumes, we know there's a restrictive process going on. If they have low flow rates, then we know there's an obstructive process going on. So let's talk about the obstructive situation. So I put some pictures over here on the side. Hopefully they help give you sort of a mental image of what's going on here. As airway resistance increases, what happens to flow rate? Well, air resistance increasing means we're going from a big lumen to a small lumen, right? That's what we're looking at here, right? That's what we're looking at here. We're going from a nice open road to now a smaller road, smaller radius, smaller opening. So how many cars can we get through this smaller obstructed road than we could when it was a full 2-lane road? A lot less. So as air resistance increases, our flow rates decrease. We can get less volume over time. We can get less through the lungs, right? And that's what we're looking at here. We're obstructing the ability for gas to move through the lungs, right? We're obstructing the ability of gas to move through the lungs. So that's going to be an obstructive disorder. So this is where we have low flow rates, right? So this is exactly what we're seeing here. Air resistance will therefore increase with a decreased airway radius, right? It's going to be a lot harder, right? There's going to be a lot more resistance to cars going through there. There's going to be a lot more resistance to gas flowing if we have a smaller lumen, right? This is all coming back to that gas. When we're looking at this, what are examples of a small airway radius? Well, two primary examples out there are asthma, like what we've seen where we have the bronchospasm and it causes it to become smaller, right, with all that smooth muscle that constricts it. And then another one is going to be emphysema, where we have the normal one. We have the good structure of the airways, right? But then with everything stretched out and destroyed, we have floppy airways. And so these airways here become floppy and they'll close. They'll open up when the patient's breathing in, but when they're exhaling, there's no structure keeping them open, so they'll collapse. And so emphysema would be another way that we'd have a small radius. If we had a tumor, right, and we talked about this in the previous screen, we had a tumor growing into the lumen of the airway, that would be a smaller airway radius. If we had a mucus plug there, if we had someone that was choking on something, that would be an obstructive disorder, right? Hopefully all those are examples that you could think through, right? And there's more out there. Mucus plugs, foreign objects we talked about, asthma, chronic bronchitis, emphysema. Those are all big obstructive situations, tumors, you name it. So whenever there's a low flow rate, then we look at this as something's obstructing the flow. So this is an obstructive process. This makes it more difficult to exhale. Why? Because not only do we have gas being obstructed from flowing in, but remember, gas has got to also flow back out. And so if something's in the way of gas flowing back out, well, gas is going to be stuck. And it's going to cause this alveoli to then expand. And then guess what? It expands and that obstruction's still there. We don't get rid of it. And therefore, even more gas gets trapped in there. And this cycle continues. So a lot of the times these patients can get some gas in because remember, what happens to your airways as you breathe in? They expand, right? Especially your respiratory and transitional airways. What happens when you exhale? What happens to the lumen of your non-cartilaginous airways? Well, they collapse, right? They're non-cartilaginous, so they collapse. So that's why it makes it more difficult to exhale, because the radius is smaller on exhale. So therefore, it makes it even tougher for them to get gas out the more and more this happens, right? So last point here, what will happen to the pressure it takes to get an adequate flow into the lungs. Oh, we're going back to Posey's law again. Thank goodness all those are recorded and you can go back and look at them. If you don't remember, if we go from a big lumen to a small lumen, just like a hose or drinking a milkshake from a big straw and then trying to drink it from a small straw, you're going to have to use more pressure to drink a milkshake from a small straw than a big straw. So it's going to take more pressure to get an adequate amount of milkshake. So more pressure to get adequate amount of flow of gas into the lungs, which means you're going to work hard to breathe. It's going to increase your work of breathing. You're going to use more accessory muscles. You're going to use your diaphragm even more, which could then ultimately lead to the skeletal fatigue of those muscles. Right? Large radius versus small radius is what we're looking at here with obstructive disorders. Just like I said before, large lumen, drinking a straw, breathing just fine. We can move a good volume of gas or a good volume of milkshake through there. But when that straw becomes a lot smaller, over here on the right, when that straw becomes smaller, that's when we have a lot harder. We have to work harder to get the flow of fluid. All right, we have to work harder to get that that volume through there, right? And so you're going to see it take a lot more pressure. If the radius is smaller, they're going to work hard to breathe. So if you see someone with asthma, emphysema, chronic bronchitis, cystic fibrosis, bronchiectasis, if you see someone with one of those obstructive diseases walking in or being wheeled into the emergency department and you see accessory muscles, you see them using their sternocleidomastoids, you see them using their muscles and working really hard to belly breathe, odds are their radius is pretty darn small. Something's causing a lot of obstruction there on that patient. What about restrictive processes? Well, this is the poor ability for the lungs to expand, right? Whether it's the lung tissue themselves or something externally, that's why I love this picture here, or something externally that's restricting the lungs from expanding, all right? So a decreased volume, when we're looking at pulmonary function test, if they have decreased or low volumes and capacities, that means there's something that's restricting the lungs from expanding. So this can be by sick lung tissue, like we see with viral pneumonias, or pulmonary fibrosis, like an interstitial lung disease like that, or it can also be by extrathoracic means, and that's why this picture here. There's something that's restricting it from expanding. The other thing that can also cause a restrictive effect is inspiratory muscle weakness. Right, inspiratory muscle weakness. So this could be lack of use. We used to see this on patients on mechanical ventilation where we would have them on the ventilator for so long, their diaphragm would actually go into atrophy, right? And then therefore they wouldn't be able to take a deep breath. It can also be from when the patient has a neuromuscular injury, right? This is supposed to be Christopher Reeve down here, pre and post. So when we're looking at that, it can also be from a neurological injury where they don't have the phrenic nerve intervention to the diaphragm, right? So they're going to have weak inspiratory muscles. Or it could also be from a neuromuscular condition like Guillain-Barré or myasthenia gravis that can decrease the ability or the strength of those muscles too. So there's a couple of different things. It could be extrathoracic, intrapulmonary, or it could be something to do with the neurochemical, the neuro communication to breathe as well. A lot of times these patients are going to have difficulty inhaling. Well, why? Because that's where you're going to be you're trying to expand the tissue. Well, there's something blocking the tissue from expanding, right? And so that's going to make it very difficult for it to expand. So let me ask you this, right? These conditions, restrictive, obstructive, or both. So a pneumothorax, what do you know about pneumothorax? Well, I know it's a bunch of gas filling the thoracic cage. Is it going to be restrictive, obstructive, or both? Well, this is going to be restrictive. What about a pleural fusion? Instead of gas filling the pleural cavity, it is fluid. filling the pleural cavity. Sometimes it could be infection, sometimes it's just overflow from something like CHF or lung cancer. So this is probably going to be restrictive. Morbid obesity, is the lung tissue have the ability to expand, or is there something sort of pushing it down and causing it to be smaller? So it's causing it to be smaller, decreasing expansion. That's going to be restrictive. Asthma, well, you know that's where you have the radius of the airways go from large to small. So this is going to be obstructive. Bronchitis. Itis is inflammation of the bronchioles. So what's happening to the radius of the airways? The radius of the airways is decreasing. So this is going to be obstructive. Pneumonia, we've already talked about this one. There's massive swelling of the respiratory zone that makes the respiratory zone restrict being expanded. So this is going to be restrictive. Third trimester of pregnancy. This is a good one. In general, this is going to be an restrictive, because it's the baby pushing against mom's diaphragm. Restrictive, my bad. Restrictive, that's an R. Restrictive, right? It's restrictive effect. It's pushing against the diaphragm, inhibiting mom's ability to expand the lung tissue, so they can have a restrictive effect. Pulmonary fibrosis, where the lung tissue develops, the respiratory zone develops scar tissue. This is going to be restrictive. And of course, it's supposed to be an R, restrictive. And then kyphoscoliosis, something from the thoracic cage, is decreasing the ability to expand. Of course, that is also going to be restrictive. All right, so what are some characteristics when we're looking at this? This is directly from your book. So these are what we're looking at. The anatomy of the affected airways, lung parenchyma, and thoracic pump is what we're looking at for restrictives. So is your airways affected? That's how I was looking at it, right? I was looking at, are the airways affected, or is the respiratory zone? Remember, parenchyma was one of those fancy terms for the respiratory zone, and I made you look at all 4 different terms for the respiratory zone because I'm like, hey, they're going to use them, and you want to know what they're talking about. Just saying. When we're looking at this with a restrictive disease, we're looking at something in the respiratory zone that's happening, or something in the thoracic situation, like something like a pneumothorax or a pleural effusion that's causing a decrease of the ability for the thoracic cage to expand, or the lungs to expand. So when we're looking at this, let's just do this. Breathing phase of difficulty. If someone has an obstructive disease, they'll have a lot harder time exhaling. If someone has a restrictive disease, they'll have a lot harder time inhaling. So if you go into a patient's room, let's say a nurse calls you into a room, a patient's having a hard time breathing. If you ask the patient, are you having trouble breathing in or breathing out, or both, it can actually help you sort of figure out if it's a restrictive, obstructive, or both. If they're having trouble breathing in, then we know there's something restricting their breathing. If they're having trouble breathing out, it's probably something obstructing their breathing. If they have both, it's probably a combined situation. What do you know? So patient assessment, there you go. Restrictive would be inspiration, obstructive would be trouble exhaling. Right, so expiration, so asthma, emphysema, and then over here, inspiration, pneumonia would be probably the bigger one in the hospital that you'll see. Pathophysiology, we're going to have an increased airway resistance, so an increase in our transairway pressure with obstructive disease. With restrictive, we're going to have decreased compliance. Overall, that's volume over pressure. Flow rates is what we're going to use to measure someone's level of obstruction. If we want to look at someone's level of restriction, we're going to look at their volumes and capacities. All right, application time. Question: you are at a Renaissance festival, consuming a medieval meal with some food and ale, right? When the court gesture makes you laugh and aspirate a large piece of bread that's now in the trachea. The court calls for the jester to be put into the dungeon for such a thing. What type of process is now present with the pulmonary system. So this is what I want you guys to do, is pause this and go through these and see if you can answer it without me answering it first, right? This is how well you've sort of paid attention or took notes to now. All right, so this is for you. So when you're ready, unpause it. Okay. So hopefully you've gone over all these. So what type of process is now present with the pulmonary system? Restrictive or obstructive? Well, is there something blocking the ability for the lungs to expand? Now we're talking about the lungs themselves, the thoracic cage or the lung tissue. Is there anything blocking the lung tissue or the thoracic cage to expand? No. All right. So therefore I know this is something that's obstructing my airways, right? Something's stuck in my trachea. All right, what would happen to breathing? Would it be trouble breathing in, breathing out? Well, if it's obstructive, it's usually going to be trouble breathing out more commonly, right? Now you're going to have anxiety. That's going to make you feel like both are the issue. But it's going to be trouble breathing out because remember, your airways close down on exhalation, and therefore the radius is even smaller on exhalation. Therefore, you'd have a lot harder time exhaling. What would happen to lung compliance? Increase, decrease? Trick question here, neither. Now, you could make the case, if we're not getting much gas to the alveoli, that it could be decreased. Okay, you could make that case, but that's not something we'll go to right now. So lung compliance, we'll just say nothing right now. What would happen to the lung volumes? Well, they actually, if air was being trapped in the lungs, the lung volumes might actually be increased, right? Remember, we have gas that can't come back out because of the radius. So that would be an increased. What would happen to the air resistance? Of course, you should have said the air resistance goes up, right? It's a lot harder to get gas to go in and out. What would happen to their flow rates? Well, their flow rates are going to be very low, right? Because gas is, it's just like going from a 4-lane highway to a 2-lane highway. It's going to be a low flow of traffic through that obstruction. How would one remedy such a situation? Hopefully someone knows the Heimlich maneuver. Get it out of there, or a bronch if it's got stuck deeper in there. Right? I told you guys I had that patient that aspirated a corn dog at Renaissance Festival, and so we had to go in with a bronchoscope and actually pull out pieces of corn dog. That was fun. All right, another situation. You are at a Comic-Con dressed as Wonder Woman with friends when you notice you're getting tired easily with trouble breathing. A friend and fellow respiratory therapist, registered respiratory therapist, looks at your pulse ox and it's at 87%. That's not great. And your heart rate's going really fast. You have a harder and harder time breathing. The costume feels like it's getting tighter. Yeah, that could happen. What type of process is now present within the pulmonary system? Once again, pause it, see if you can answer these questions. Okay, so what type of process is now present in the pulmonary system? You should have said, hey, this looks like a restrictive process. That's a tight costume that he's wearing there. What would happen to his breathing? Trouble breathing in or breathing out? Well, this is going to be something restricting his chest wall, so it'll be trouble breathing in, right? What would happen to his lung compliance? Well, the ability for the lungs to stretch is decreased. What happens when what would happen to the lung volumes? All right, the ability for the lungs to expand is going to be decreased. All right, what would happen to airway resistance? Well, air resistance is not really going to change here. And then what would happen to the flow rate? Well, will anything change with the flow rate? No, so nothing will really happen. It would be normal. How would one remedy this situation? Change into an appropriate sized Wonder Woman costume, please. Or find a seamstress that's there with you or something like that. Who knows? All right, so what is some of the equipment we use when we're looking at this? Pneumotachometers, by definition, is a device that measures flow and it converts it to a volume. And that's what we use for our equipment. It measures flow and it converts it to a volume. We use it, the bedside equipment, and we also use something called the body box or body plasmography. Yeah, fancy word there. You can impress people at Comic-Con parties with that. Well, maybe not common part. Anyway, we're going to use a 3-liter syringe at 3 different flow rates: a slow flow rate, a medium flow rate, and a fast flow rate. This was actually a speedable question that our team missed in the finals, but we still won the championship. Just saying, they missed that it was 3 flow rates: slow, medium, and fast. So now you know, and hopefully you remember. Notice it's in bold because I was a little upset that they didn't remember. Anyway, so it's a 3-liter syringe at 3 different flow rates: slow, medium, and fast, that determines how accurate it is. Here's a video that's embedded in here, so you'll have to click on that on the actual presentation, or you can pause it and type it in. There are other ways to calibrate the equipment. You can use a rotometer. This is a flow generating device, and it makes flows very reproducible compared to us just using the super syringe. There's the sine wave rotary pump, which also simulates flows. This one uses it for the body box and MVV calibration, so this is not something you would use on the bedside equipment. It's something you would use in the pulmonary function lab. And there's something also called an explosive decompression device that also simulates flows in a forced maneuver. But traditionally, when you're looking at almost all of these, I want you to really remember that the 3-liter super syringe at 3 flow rates is sort of the gold standard still, even though there's more accurate ways, or other ways I should say, to do it. This is still the one that's most commonly used out there, and the least expensive of the 3, I would think. Just get that 3-liter super syringe, that guy there, and you're going to use that little handle, pull it in, pull it out, and then hopefully you watch that video and see it calibrate. The body box. Whose law is this based on? I will give you a hint. The next two, instead of doing the first one, it looks at pressure and volume varying inversely while temperature and mass is constant. Of course, you should have said loudly, Derek. That is Boyle's law, right? Boyle's law of pressure and volume varying inversely. That's how the body box works. So we put this patient in this sort of chamber, and I got some pictures on the next slides on this. And we close the chamber, and it's glass and see-through and all that stuff. And we can look at total lung capacity and functional residual capacity. We can also look at it. It measures airway resistance. If we close this shutter, so you guys see the shutter here? If we close that shutter and have them pant, we can see how much resistance there is to gas flowing in their lungs as well. So we can measure flows for airway resistance, right? Remember the calculation for air resistance? Well, the unit is centimeters water per liter per second, so it's pressure over flow in liters per second. Yes? Hopefully you remember that. There's a reason why we went over that before. It has a shutter that also closes for total lung capacity. So we know what the capacity or the volume of the box is. We know that the remaining capacity when that shutter closes is in the lungs. So we know what their total lung capacity is, right? Big disadvantages is some people are unable to enter the box just because of their body habitus or claustrophobia, or some people might not be able to do the procedure where they have to pant for the airway resistance. So you have to put your hands over your cheeks and then puff, or pant, I should say, pant for the airway resistance maneuver. And some people may be unable to sort of coordinate that type of breathing as well. So some of those are disadvantages. We calibrate it with a barometer for the mouth pressure. Box pressure, we can use that sine wave rotary pump, and then a pneumotac we can use a rotometer if we need to. Right, and so this is sort of what we're looking at: pressure of the chamber, pressure of the airway, and so we can look at the patient's functional residual capacity, and then we can look at ultimately their total lung capacity, because we're just comparing the two pressures, the pressure inside the box itself, the pressure inside the airway, so we can see the difference between the two, and that would help us determine their lung volume and capacities. These are also different pictures of the same thing. These are the signals that we're going to get as the patient is inhaling. It's going to go to a negative waveform down here. As the patient is exhaling, it's going to be a positive or a vertical inflection as they're doing that. When we're patients inhaling, over here on the right here. If the patient's inhaling, the flow is going to be going down because they're pulling it into their lungs, but the box pressure will be going up as a positive inflection because there's more pressure there. So just so if you do see a patient in a body box at clinicals, you sort of understand what you're seeing. The patient's inhaling, so flow's going down and pressure's going up, and then they're exhaling, flow's going up and pressure's going down because you're looking at box pressure, right? So you're just exchanging volume and pressure, which is Boyle's law ultimately. Here you're seeing the shutter close. You might see that little skip there, and then box pressure, so you see it going up and down as they breathe. So that's what causes the waveform changes. This is the picture, a better picture, a non-cartoon picture. You put the patient, there's a little handle here. You put the patient in there, you close it, and then you can still sort of hear each other, and you're coaching, you're at the computer, and you're still coaching them through the breathing procedure itself. And so they're just in the box. It's not too big. It's like an old phone booth, if you ever remember one of those things. And we even do this with little children. Little kids can go into these things. As young as like 4 years old can do some types of pulmonary function testing if they're able to follow the directions and the procedure to do it. So you'll also see in this one with this kid doing the pulmonary function test, the kid is wearing nose clips. And that's to help prevent gas from sort of escaping through the nose so we don't lose flow or volume. It helps the numbers be a little bit more accurate that way. So what are some other equipment we use? So that's the body box. That's what we would use in a pulmonary function lab traditionally. But what's something someone can use at home to look at their flow rates? If they have asthma, and I want to trend their asthma at home, how severe it is in the morning, how it is at night, or when there's smoke in the air or allergens in the air. I want that patient to sort of trend where they're at in their flow rate or how bad their obstruction is. Well, this is something they can take home, and this is what you see down here. And there's different versions. It's called a peak flow meter, and we use them in the hospital too. So this, you have the patient take a deep breath in and then blow out, and it moves this little measuring here up on that dial or on that level there, and it tells you how fast the patient exhaled. The faster the expiratory flow rate, the further it goes. So they forcefully blow into the device, it moves the indicator, and it's going to look at their flow rate. So you can look at it on the scale. You don't have to convert anything. It's available in liters per minute. It does it in liters per minute. So you have low flow rates for your pediatric geriatric patients, and you have high flow rates for your sort of preteen through normal adulthood patients, or your severe asthmatic patients who are probably, they get severe enough you have to move to the low flow rate one. Here and there. Accuracy can be affected by patient efforts. That's a big downside here, and that's one of the reasons why PFTs take such good coaching. And you need to be a good coach. Get as much effort as you can out of that patient. You can't be, okay, take a deep breath, blow as hard as you can, right? You're not going to be Eeyore. You are going to be Tigger. You are going to be a bouncy tiger that is just getting as much energy out of this patient to give you the best test. And so this is why we usually have them do 3 efforts, and I'll take the best number of the 3 efforts because it's effort dependent. We're not going to average it. We're just going to take the best number. So do it 3 times, stand up, big deep breath in, blow it really hard, really fast, right? It's like you're blowing out candles on a cake or something like that. and you really want to get the best effort you can out of them. And kids, in my experience, usually tend to have more effort giving than adults, but that's a whole separate thing. But when we're doing this, make sure that you do as much effort as you can, get as much effort as you can out of the patient, and then record the best value out of those 3 blows. So, what type of patients would this be used for? Obstructive or restrictive? Or both? Which one? Hopefully you said obstructive. Good job. All right, how do we know someone's normal value, right? So we need to know the upper of normal limit and the lower of normal limit to see if their lung function's okay or not. So we're going to compare the value that the patient gets on the equipment to what's normal for them. So this is just a pretty simple calculation, just like calculating a grade. You're going to take how many questions you got right over the normal amount of questions that the test holds, and then that tells you your score, right? Well, same thing here. We're going to take the patient's measured value over their predicted value and then move the decimal over, which is this part here. And we're going to look at this percent predicted, which would look at the severity of the process. So let's do a example. So if a patient has predicted value of 6 liters and the patient's measured value is 4.7 liters, what is their percent of predicted? How much of that 6 liters did they get? Well, 6 gets kicked out. 4.7. However you do the math, right? This is just me being old. So it's going to be 0.78. So this is going to be 78% when I do the 100 thing. So 78% of predicted. So the patient got 78% of what was predicted for them. The question then becomes, is that a good value? Is 78% a good score, or is 78% a bad score? Well, let's go to the next screen. So a normal, when we're looking at this, would be 80 to 120% of predicted. So this 78% on the previous screen is that patient within the normal limits of their volume, right? 4.7 liters out of 6 liters. No, they're not normal. So they're 78%. So this patient had a mild restrictive process. Why did I say restricted? Because we're looking at volume, right? Volume and capacity is restrictive. Flow rate is obstructive. So in the restrictive category, this patient would have a mild restrictive disorder, right? So then that determines the severity. This patient has a mild restrictive disorder, or is 60-69 would be moderate, and so on and so forth. Very severe, I've seen that before. We had a patient that had cystic fibrosis and was in her 3rd trimester of pregnancy. So not only were her flow rates low, her volumes were extremely low, and she was at 22%. Crazy. And she did great. Awesome. So when we're looking at something like this, that's how we sort of determine the severity, and that's how severe that previous patient's or example that we talked about, that 78% would be a mild restrictive effect. All right, and so this is directly from your book, and this would be looking at obstruction here, right? Normal for a FEV1 would be an 80 to 120. Mild would be 70-79. Moderate, severe, and then low. And then when we're looking at restriction, same thing, 80 to 120 would be your normal limits. Notice that you're sort of seeing some repetition here. This is good. This is very good. DLCOs, notice some repetition here. Normal is 80 to 120% of predicted. And then this is what changes a little bit. 61 to 79 would be a mild diffusion defect. So if the DLCO is low, that means their diffusion is low, right? So this would be a sign of something like emphysema. right? Emphysema. Emphysema, right? That's just a sign of would be emphysema and or something like pulmonary fibrosis. So there's two primary things that can cause the DLCO to go down. Either something like emphysema, where remember a normal alveolus, and then emphysema, we have that sort of destroyed alveolus and the capillaries destroyed too. So emphysema, you would have an obstructive pulmonary function test with a low DLCO, and then you know it's emphysema. So if you have a low DLCO and the PFT shows obstructive, you know it's emphysema. If you have low volumes and flow rates, if you have low volumes and a low DLCO, it's probably something like pulmonary fibrosis, right? Something that's causing that diffusion to be impaired because of scar tissue building up with the alveoli itself. So we know if you do a PFT and it's obstructive with a low DLCO, it's a sign of emphysema. Everything else, it's hard to know which PFTs will cause. So if we do a pulmonary function test on someone and we have low flow rates, it could be chronic bronchitis, could be asthma, could be emphysema, right? It could be cystic fibrosis, bronchiectasis. When we're looking at that, we don't know which one of those it is. The only way we can tell emphysema from the rest of the obstructive disorders on a pulmonary function test is if it also includes a low DLCO. So if you see an obstructive PFT, one with low flow rates, and you see a low DLCO, we know it's emphysema. If you see just low volumes and capacities, then you know it's not emphysema, it's something else. It's probably some sort of interstitial lung disease that's going on, some scar tissue, something like that's causing that decreased in diffusion. All right, so how do we predict someone's normal value, right? Like we talked about before, we knew how to calculate what they got out of normal, like the 4.6 out of 6. That's how we predicted, that's how we got how much they did, right? How well they did. But how do I know someone's normal value? Well, there are three big variables here. The big ones, and this is in order of most significant to least significant, is their height, their sex, and their age. The height is going to be like the size of the thoracic cage. And so that's the height of the patient's going to play in big. If you have someone that's 6'10" and someone that's 5'6", they're going to have different sizes of thoracic cage. Their rib cage is going to be different. So therefore, their volume of their lungs and the flow rates of the lungs are going to be different. Same thing. Genetic male and female, when we're looking at those genetics, we're going to see that the thoracic cage will make a variance between the two. And then age, right? Age can play a role in there. It's not as big, but it also can play a role. And this is where we use something called a nomogram, and that's what we're going to look at on the next screen. These were more common before this whole computer thing happened, which who knows if computers are going to catch on or not. So when we're looking at this is how they used to do this. So let's look at a nomogram for good old time's sake. A nomogram, so you're like, Derek, how do I use this? So I take my height, and so if I'm, and this would be for genetic males, if I am 5 foot, what is it? 61 inches would be like 5'1". So I'm going to use a straight edge, and then I'm going to say that my age in years is 20 to 90. And then FEV, and then it tells me my predicted. So I'm just going to use a straight edge. So let's say I'm 153 centimeters or 5'1", and I'm 20, which I'm not. And then we're just going to draw, hopefully, a straight line through. You're going to have to pretend that's a straight line. All right, so this will tell me my predicted value for my FEF 25 to 75. It'll tell me my predicted value for my 200 to 1200. It'll tell me my predicted value for my FEV1, and then it'll tell me my predicted value for my FVC. based upon those factors. So you'd use a straight edge, and that's how they used to determine that. Now it's just an Excel program. Little calculation, genetic female, same thing. If I'm 5'1" and 30 years old, that would be all my predicted for my 25 to 75, FEV1, 200 to 1200, and forced vital capacity. All right, so you just line it up between the age and the height, and then it would give you your predicteds. But you guys won't have to worry about that. It's just fun. I like history for some reason or another. Spirometry. Spirometry is the measurement of the amount of air entering and exiting your lungs, right? So we're measuring the air. And so the two things that we're looking at with bedside spirometry, so this is what they might call it in the hospital, bedside spirometry, right? So they just want to see two things. I want to see volume, how much volume can the lungs hold, and I want to see how fast the gas flow is, right? So I want to see volume over here, which would be restrictive, looking at restrictive effect. And then over here, I want to see how fast it goes, which would be obstructive effect, right? So like asthma, emphysema, and over here, restrictive, it would be like pneumonia, right? So how fast it goes, that would be your flow rates, like obstructive disorders, or how much volume or capacity it has would be restrictive disorders. So what are the volumes? How many are there? Do you guys remember? Hopefully you all remember. There should be 4 volumes. Do you guys remember the box? So we should have the box. I always did whatever order you did it. IRV, VT, ERV, and then RV. Yeah, you cannot make those out. So this one would be inspiratory, reserve volume, tidal volume, expiratory reserve volume, and residual volume. So there's 4 volumes. Which ones would be increased with air trapping? Well, remember, air trapping is done at end exhalation. So we're going to look at the exhalation side. So that would be ERV. It would be pretty much the RV being increased and restricting, pushing up and taking space. So that's going to be increased with air trapping. Residual volume is going to be increased with air trapping. So that's air that can't be exhaled. If you remember the definition for residual volume, air that cannot be exhaled. So my residual volume would be increased. Which ones would be decreased with the restrictive disorders? Well, it would also be expiratory volumes. When we're looking at this, decreased with restrictive disorders, all my volumes are going to be decreased. My IRV, my ERV, my tidal volume, all of them, even the RV, are all going to be decreased with restrictive disorders. So with restrictive disorders, all of them go down. My tidal volume would go down. My inspiratory reserve volume would go down. My expiratory reserve volume would go down. My residual volume, all those would go down with a restrictive disorder. With air trapping, usually we're looking at residual volume. That would actually go up because we're getting gas that we cannot exhale. It's trapped. So that's why it's just residual volume there. Capacities. What defines the capacities? Remember, it is 2 or more volumes. How many are there? Remember, there are 4 capacities. There's TLC or TGV, vital capacity, inspiratory capacity, and functional residual capacity. So there are 4 of them. That's what they are. Which ones would be increased with air trapping? Well, in this situation, the only one that has the expiratory part of it would be your functional residual capacity. So FRC would be increased in air trapping. So if you did a pulmonary function test and someone had a very high FRC and very low flow rates, that's a big sign of an obstructive air trapping patient. Which ones would be decreased with restrictive disorders? Well, all of them. TLC would be low, vital capacity would be low, inspiratory capacity would be low, functional residual capacity would also be low. So all of these would be low with a restrictive disorder. Hopefully you guys like these little questions in here for us to go through together. All right, I think this is the last slide, and then we'll go on to version 2. This is hopefully something you remember from the last class, and this is just where we're adding percents to this whole thing. When we're having a patient breathe for a pulmonary function test, this is what we're looking at here, and I'll use red here. So we're going to have the patient breathe tidal volume, which is just in and out, just quiet breathing in and out. Then we're going to say take a deep breath in, as deep as you can to the maximal level, and then force that breath all the way out till they can't exhale anymore, so they hit down to the residual volume. And then once they're all the way out, go back to breathing normally again, right? As much as they can. So tidal volume is just your normal quiet breathing here. When we're looking at inspiratory reserve volume, that's this whole area up here, right? A lot of area, and so that's 40%. Your IRV is 40% of your lung capacity, right? That's that whole area. Your tidal volume, you're only using 10% of your lung capacity right now, as long as you're not like running on a treadmill, right? So you're only using 10% of your lung capacity right now just for quiet breathing. And then your ERV, it's a little bit different. That's going to be about 30% of your lung capacity right down here. This is your ERV, right? Resting expiratory level. So that's as much as you can exhale past a normal expiratory thing. So if you quietly exhale now and then force as much out as you can until you're all the way empty, that's your ERV that you just went through. So that's 30% of your lung capacity. And finally, at the very end, you're going to have your residual volume, which is 20% of your lung capacity. You do need to know these percentages, all of these percents. Like TLC is pretty easy to remember, 100% of the lung capacity. Vital capacity should be 80% of the lung capacity, 80%. And then we know that the residual volume is what's left over. So when we're looking at these, it's going to be important to see what percentages the patient has and what's increased. So if their FRC is greater than 50% of their lung capacity, that's a sign that they're air trapping, right? So we can get their lung capacity from a body box, from a pulmonary function test. There are 3 primary ways to measure someone's lung capacity, TLC. We can put them in a body box. We can do what's called a nitrogen washout. The nitrogen washout is where they breathe 100% oxygen to wash out the nitrogen, right? So they could do a nitrogen washout, or they can do a helium dilution. Now there's a 4th way in theory where they could do it from an X-ray or CT scan. I won't question you on that here, but there's 3 primary ways we can measure someone's total lung capacity: body box, so body plethysmography; nitrogen washout, where they breathe in 100% oxygen; and helium dilution, and you'll read about these in your book as well. So those are the 3 primary ways that we can do this. You do need to know the percentages of all these, and remember when we went through this in pulmonary, we also talked about if I were to say I have TLC minus residual volume, what would that equal? Well, TLC minus residual volume would be vital capacity, right? Because that's what's left over. So TLC, and I subtract residual volume, that would be vital capacity that's left over. So make sure you know what constituents make it up, and then you draw your volume and capacity box, or you remember or are proficient with getting your volume and capacity box together.